Well, Rick, in the first section of this activity, we reviewed the essential features of fibromyalgia. And we talked about a case that we both agreed was a pretty typical presentation that we both see in our practice. However, in many instances, a diagnosis of fibromyalgia can be a lot more complex. Comorbid medical or psychiatric conditions can kind of compound the presentation. And it's pretty well known that several particular medical and psychiatric conditions seem to coexist more frequently with fibromyalgia. For example, post-traumatic stress disorder, chronic fatigue syndrome, migraine headache, depression, anxiety, and even rheumatic diseases such as lupus and rheumatoid arthritis. They are several times more common in persons with fibromyalgia. And because fibromyalgia has the absence of a really solid gold standard definition, it can get a little fuzzy. Pain, fatigue, mood changes often come with, a number of chronic medical conditions, don't you think?
Oh, absolutely. And I think of several rheumatoid arthritis and lupus patients we have in the practice who they come in with increased pain, and it's incumbent upon us to figure out whether this is the inflammatory component or whether it's a secondary fibromyalgia component. Not only that, but a lot of these patients also have psychiatric disorders on top of it. So now you're adding a psychiatric disorder with an inflammatory arthritis such as lupus or RA, and they have increased pain with secondary fibromyalgia. And I think if you've seen this, which I'm sure you have, a lot of our day is spent trying to figure out what's the primary generator of the pain. And it can be quite difficult.
Yeah, patients find it very hard. Folks like this who have a number of kind of comorbid conditions in the mix, they find it hard to be able to really tell us clearly. They can't really focus very well on the local areas of pain. I was going to tell you about a case that I saw recently that I think illustrates this well. It was an Afro-American man married with 2 children. He's about 38 years old. He had a history of lupus nephritis, not a trivial illness. And he had undergone several invasive procedures, which were very upsetting to him, and was treated with aggressive cytotoxic agents for his nephritis. And he had been hospitalized a lot and lost his job as a result of this. Lately, his disease activity, according to our rheumatologic evaluation, had been pretty good. His disease was stable on Plaquenil and prednisone, low-dose prednisone. But he comes in complaining of a little bit of malaise, low-grade fever, pain in his hands and his feet, and sleeping poorly. But when I examined him, he had no rash, none of the typical rash of lupus, no hair loss or oral ulcers, serositis. Those are the things you often see with active lupus. And when I examined his hands, he had no frank synovitis. Like you were saying in the other case, he had no hot, swollen joints. It was not juicy. But his grip strength was noticeably weaker. When I looked at his labs, his SED rate was a little elevated, not much, 32. He had a stable low white count, but his urine sediment was not active, and his kidney function was normal, was what it had been at baseline. Mm-hmm. So, those things were good. And it is hard to know what's what. Like, his sedimentation rate is up, but that could be his lupus, and, it's very nonspecific. But it was reassuring that his other labs, particularly his urine and his kidney function, were stable. So, on the one hand, he had none of the cardinal features of active lupus, but he did say he had these low-grade fevers. But, in the office, he had no elevated temperature. He says his hands hurt, but I felt no synovitis, but his grip strength did seem weaker. So, maybe he has early synovitis, maybe not. Maybe his symptoms of fatigue and malaise are lupus related. Maybe it's just related to poor quality sleep. So I think that these are hard to sort out. It's hard to know what is what, and it's important to know the core disease, to know about his lupus, for example.
Right. And that's a great case. It's a difficult one, as you know. And with each one of the complaints, I would have to go down my list of questions. Particularly the fever would bother me, or at least the stated fever, whether it's actual or not. Right. And then the malaise along with the hands. The fact that he doesn't have synovitis, that his urinalysis is not active, and that his renal functions are the same, suggests that he probably doesn't have anything going on lupus-wise. But again, those are very, very difficult situations, and I think are hard to sort out. And I think that's a case where I would say something other than the lupus is definitely active.
Right. I mean, it's a challenge not to ascribe all the symptoms to one or the other disorder. And I think it takes knowing the core disease, and if we don't, this clearly is a case that probably requires coordination with the subspecialist.
Absolutely.